Okay, thanks everyone for logging in today for this month's iteration of the CTTG Research Methodology Lecture Series. We are very fortunate to have Dr. Deborah Siegel joining us today. Deb is a hematologist and clinician scientist and associate professor in the Department of Medicine and School of Epidemiology and Public Health at the University of Ottawa, and an associate scientist at the Ottawa Hospital Research Institute. She holds a Tier 2 Canada Research Chair in Anticoagulant Management of Cardiovascular Disease. Her educational background includes a BSc in Physiology at McGill, a Master's of Science in Pharmacology at U of T, an MD at Queen's, an MSc in Health Research Methodology at McMaster, and she has published over 120 peer-reviewed articles in a number of very high-impact journals, including the New England Journal of Medicine, Annals of Internal Medicine Circulation, Journal of the American College of Cardiology, and so on and so forth. And has, in addition, published some studies that are of direct relevance to transfusion practice in regards to blood conservation efforts in the ICU. And she is going to be talking to us today on the subject of explanatory versus pragmatic trial design. And with that, I will turn it over to Dr. Siegel.
Thank you so much for the kind introduction. I'm like, oh, that bio needs updating. But I did, all of those things are true, especially about having worked in the space of transfusion medicine. So it's such a pleasure for me to be here and to talk about this topic. Let me just make sure you guys can see my slides. It's funny, I was just reflecting recently in thromboland, it's not necessarily well known that I'm a clinical, I'm a pragmatic trialist, but, having worked in this space and conducted a large pragmatic cluster trial, to reduce transfusion, I feel like I'm at home here. So thank you so much for inviting me. This is like one of my favorite things to talk about. Okay, I'm just going to see if I can reduce this video thing. Okay. Okay, so today we're going to talk about pragmatic versus explanatory trials, and I'm going to share my experience having designed and conducted one, and hopefully we'll have some time for questions at the end. That would be great. The objectives that I'm hoping to accomplish today are that you'll walk away from this presentation with an ability to define and distinguish pragmatic and explanatory trial designs. And this is a bit of an evolving topic. So, I'll kind of allude to that in some of the upcoming slides. Apply the kind of pragmatic explanatory lens. Sorry, one sec. To trials in transfusion medicine, and then discuss some practical considerations. I actually, recognizing that you're having an upcoming lecture by Monica Talliard on cluster trials, I actually removed some of I removed the ethical considerations from this presentation, just for that reason, because she's, I'm sure, going to go through some of that with you. So I wanted to, start here because I think this is actually where it all begins, obviously, and where it begins in terms of considering, pragmatic versus explanatory. Obviously, we're conducting research, and as I always say to people, trainees, the most important thing is identifying the problem you want to solve. What is the clinical problem you're trying to solve? And usually that comes from our patients and our clinical experience. Of course, you're going to gather your scientific team, and then there's this research question development piece, which ties in really importantly with this selecting the study design. And the reason I wanted to bring this up is because it's quite germane for the discussion we're having today about how you really design your trial with the consideration of whether your aim is to be explanatory or whether your aim is to be pragmatic or a little bit of both. And so, of course, pragmatism in clinical trials arose from concerns that, clinical trials didn't adequately inform clinical practice. And there's these natural tensions when you're designing clinical trials, because on one hand, we may be trying to provide insight into a therapeutic mechanism. So, giving a medication or a treatment or a protocol or device that has a cause and effect type relationship. But also, there's this desire or need to guide decisions about what works in everyday practice. And I think, probably everybody in the Zoom room can appreciate that these tensions. We gather great evidence, we have lots of good clinical trials, but, an important challenge is, how to implement them into clinical practice and how they should guide clinical practice. And so I think this topic is pretty important. And so when we're thinking about explanatory versus pragmatic trial design, these concepts sort of evolved in the late 1960s. Um, uh, Proposed by some researchers, but it's useful to consider these concepts dichotomously, like they're separate concepts. But very few clinical trials are purely explanatory and purely pragmatic. And current concepts actually support that there's a spectrum. And I would actually argue that even more current concepts are actually proposing that they are separate, related, and complementary approaches. So some trials, are by nature very explanatory, and other trials are by nature very pragmatic, but very few of them are, truly either one of those things alone. So an explanatory trial answers the question, or it's designed to answer the question of whether an intervention can work under ideal conditions. And this is a lot of the traditional clinical trials that we're familiar with. These are trials that have a highly selected patient population, so very strict inclusion and exclusion criteria, rigid protocols, very standardized. These are trials that are separate from usual care, often done by special study teams that have, specific expertise, research coordinators, et cetera. And they're concerned primarily with efficacy. Again, does this intervention work? Is there a cause-effect a relationship? And they really optimize internal validity. So they're designed to have internal validity, and I'm going to explain what that is in the next slide. Whereas a pragmatic trial is designed to answer the question of, does an intervention work under usual conditions? And folks may be familiar with these types of trials. There's a broader population. Often these can involve complex interventions, so policy type interventions or protocols. They're conducted in the usual care setting, often conducted wholly or in part by the clinical care team themselves, and they're concerned with effectiveness and have a high degree of external validity or generalizability. And so when we talk about validity, I just thought it was important to mention what these are. Internal validity, remember, this is kind of like, that high degree of internal validity with explanatory trials. This is the extent to which the observed differences between groups is attributed to the intervention here. So we're able to say, this intervention had this effect. Whereas external validity is the extent to which the study results can be generalized to the population. And I think to some extent, researchers talk about, a tension between these two, and certainly there is that, when it plays out in clinical trials, and we're trying to, focus on the right type of design for the right type of trial. I think what researchers propose is that trial designs should be fit for purpose. So it's important at the outset to establish whether you want to have an explanatory intention. So for example, you're testing a hypothesis about a treatment effect on a specific causal mechanism, right? So intervention causes a certain effect, or a pragmatic intention, which is to help decision makers choose between interventions, and decision makers here could be, patients, policymakers, physicians, researchers. So I think pragmatic trials really were first proposed as a way to provide results that are more applicable to clinical practice and decision making that has to happen. Whereas an explanatory approach really leads to tightly controlled trials under ideal conditions that really help us understand how the treatments work. And both have an important role in healthcare, because of course you can imagine, with novel drug design and development, to some extent, we need explanatory information about how that drug works and proof of principle. But it's really important that we pay attention to both internal and external validity, and I think that's where this tension plays out. And so some newer concepts in this space, at least since I, had done my master's, and this was something that was a big part of my master's thesis, was around this issue of pragmatic trials and, how they fit in and where they fit in. But, there are, new ideas sort of suggest that pragmaticism and explanatorism, which is a word, are distinct but compatible and not necessarily extremes of a continuum. And that, 20 or 40 years on from when these concepts were developed, modern trial now designs allow the incorporation of both pragmatic and explanatory questions or elements in the same trial. And in particular, these trials are possible because we can leverage, digital information from healthcare and also within clinical research. So things have changed over time. Technology has changed, which has allowed us to maybe incorporate these in a way that was not possible when these concepts were first developed. So if we think about traditional randomized controlled trials, so explanatory randomized controlled trials, essentially these are trials that are designed to reduce the chance that another factor other than the intervention under study influences the outcome. That's how they maximize internal validity. And so the advantages of these trials are, again, that they have high internal validity, that the differences that we see, are due to a treatment effect or to chance, and that has to do with how you set up your sample size. And then the analysis is pretty straightforward. It's simple. It's intuitive, easy for people to understand. You may be familiar, traditional randomized controlled trials with hazard ratios. We're sort of all familiar with reading those types of trials. Some other novel types of designs can be a bit more challenging, to incorporate into practice. Sometimes they're harder to understand. Other analyses like win ratio or RMST, or even, some of the Bayesian approaches that people are taking. So just to give you an example, these ones, that's a huge benefit of a traditional or highly explanatory traditional randomized controlled trial. The disadvantages, which people are probably familiar with having worked in this space, is that they have low external validity, right? These are not highly generalizable. And this is a really common discussion point. They are very expensive to conduct, and they are slow to conduct, and the results are slow to implement into clinical practice. And they are not always patient-centered. So you can have a patient-centered traditional randomized control trial. I think, we've seen more and more of these, but often they may be, I'm thinking of the oncology space with like things like progression-free survival or some biomarker change that may not be patient-centered. And these are really the widely cited challenges of traditional randomized control trials. We talked about slow to conduct and implement, really expensive, not just expensive, resource intensive and logistically complicated. So folks talk about these trials not necessarily being relevant to practice because they're really conducted outside of the clinical practice space, not where patients are actually treated. And these kinds of trials, although we do have great randomized trials, you don't really provide enough evidence, enough trials with enough evidence to actually inform clinical practice. And so you see this all the time where we have all these findings published in the New England Journal of Medicine and important findings that could really improve care for patients potentially, but just not implemented and for various reasons. And implementation is a whole different topic, a very interesting challenge. And I like this quote, which is, if we want more evidence-based practice, we need more practice-based evidence. And so I think that really sets the stage nicely for why pragmatic trials are so important. So again, the point is often discussed that traditional randomized controlled trials have limited generalizability. And this is a systematic review, a literature review on the representativeness of sample sizes and implications. And so in this review, they found that participants in 71% of trials that they looked at are different in important ways from the patients in the setting that the treatment would be used once approved. So, again, highly problematic because the clinician in the hospital or in the clinic is thinking like, how do I apply these results to my patient? They wouldn't have met the criteria for this trial. The trial was a different type of population, although the patient has this disease. So really tricky. So what are pragmatic trials? And I think people have different ideas about what this means. Ideally, these are trials that are designed to test interventions in clinical practice settings. And again, they focus on effectiveness rather than efficacy. And they really aim to support decision-making for clinicians, policymakers, and patients. And so when we think about pragmatic trials, sort of it incorporates research, policy, practice, right? But there can be elements of pragmaticism embedded within other types of trials or more explanatory design. So I think, again, there's some spectrum here that can be applied when designing these types of trials with some pragmatic components. So some of the characteristics of pragmatic trials include these things. They may have research questions that are directly from or important to stakeholders, and we're seeing this more now, right, with the engagement of people with lived experience in trial design. they often have diverse or representative populations. They're conducted in heterogeneous settings. The outcomes of these trials are important to decision and policymakers. And we're seeing, more and more, funders and others seeking to include outcomes that are important to patients as well. Also, you see in these trials kind of quote real world alternatives, not placebo or no treatment. And I highlighted real world in scare quotes because I actually really don't like the phrase real world. For some reason we've adopted, it's just my little rant that, I think it's important to remember that patients in clinical trials are actual patients. They're not although these trials are often conducted separate from clinical care, they're still patients. There still are patients that we're treating, on a clinical trial, and they volunteered to do so. So I sort of hesitate to use the word real world because it implies that people in clinical trials are not real, which they are. It's just helpful to remember that. So the advantages of pragmatic clinical trials, again, so these are trials that evaluate the effects of an intervention in usual care settings, which maximizes the generalizability, and also, though, does come at the expense of internal validity, right? Because we don't have that same sense of cause and effect that we can be certain about. But often they use routinely collected data, and I'm going to show you an example of the trial that we conducted that used exclusively routinely collected data. That's super pragmatic. They are lower in cost to conduct, and again, they gather information that can inform researchers, policymakers, and patients. The disadvantages are that there's low internal validity. Their designs are less familiar, and certainly from my colleagues, I hear this all the time. Nobody understands cluster trials. They're difficult to understand. So it is an issue, an important knowledge translation issue when you're embarking on this type of trial to think about how you're going to present the results so that people can understand. The data quality is dependent on the clinical systems, and we certainly experienced that in our trial where we used information from 25 different hospitals, downloaded into 25 data sets, and so cleaning those data was actually a big challenge. And then the analysis is more complex, not as intuitive as that sort of traditional individual patient randomized trial that people are familiar with. Yeah, people you may or may not be familiar with this tool. So this is a tool called the Pragmatic Explanatory Continuum Indicator Summary, or PRECIS, which was initially designed to help trialists think more carefully about the impact that their design decisions would have on applicability, right? And this tool has since been updated, and now there's a PRECIS 2, and I think there's a PRECIS 3 coming out. So you can see on the right-hand side, this is a 9-spoked wheel that has 9 domains based on different trial design decisions. And so it represents kind of how explanatory or pragmatic a trial is on that sort of continuum. So trials that are more explanatory are, you'd see like a circle closer to that, middle hub, whereas trials that are more pragmatic are closer to the rim. So the way that you would use this tool is to first identify, and again, going back to the beginning of the talk, is why are you doing your trial? Do you have an intention to be pragmatic or explanatory? And that's really important. And I think that's emphasized actually if you read this nice document. They also have a great website with resources. So I encourage people to take a look at that. You want to consider the trial design choices for each of these domains, and then you plot, how pragmatic or how explanatory on the wheel. There's also a table that you can use if you prefer a table. And then again, review the design choices to ensure that your trial that you've designed supports the aim that you had at the beginning there in step 1. So it's a way for people to, visually represent this, but also, to work through those design features. And so, again, if you end up with a trial that's, kind of at odds with what you had intended to do, you can go back and make some changes to that. So is really the focus here is on intentionality. I just wanted to briefly go through the domains because I think they're sort of interesting. The first domain is eligibility, and this really it addresses to what extent the participants in the trial are like those who would receive the intervention if it was part of usual care. So here we're talking about like issues of generalizability. Recruitment. So how much extra effort is made to recruit participants over and above what would be done in usual care to engage with patients. for the setting is how different is the setting of the trial from the anticipated usual care setting. You can see how these are getting at different aspects of pragmatic versus explanatory here, right? For organization, this gets at how different are the resources, expertise, and organization of care delivery compared to a usual care. So imagine a trial where you're doing a phase 1, like first in human, and people have to, like be in a setting and have blood drawn every 5 hours or something like that. I mean, obviously that's very different than people having their routine care done and there's no additional testing that's required. For the flexibility of delivery, really addresses how different is the flexibility of delivery from that in usual care. So, you can imagine an intervention, again, that's above and beyond care, some sort of treatment that's new or special or different versus maybe a treatment that's already being used in clinical care. And I'll talk about the small tubes trial that we did. How different is flexibility in monitoring patients or encouraging adherence? And often in very explanatory trials, it's really important for internal validity for us to know that the patient or participant took their medication on the right day at the right time. And there's a lot of efforts that go into ensuring adherence compared to usual care, which is what you would see in routine practice. Follow-up here addresses how intrusive in measurement and follow-up of the participants versus usual care. So, tests and procedures and assessments. Primary outcome, again, this addresses whether the primary outcome is directly relevant to participants or, more of a surrogate outcome. And then finally, to what extent are all the data included in the analysis? So it's a lot to take in, but I think you can appreciate that these domains really do capture, aspects of the design where there needs to be a decision about an explanatory or pragmatic approach. And then there's kind of a spectrum within that. Now, I think the updated Presses 3 is going to add some additional domains, and so when I was thinking about this tool, I also thought about, the critical appraisal of literature. So like what happens once the trial is done and is now ready for prime time? And this is just an approach from the user's guide to the medical literature. It's referenced on the bottom. It's a really great resource about critical appraisal of studies. And so, this is from the chapter regarding randomized trials or therapy. And so you can see here reflected in this assessment of critical appraisal, were the study patients similar to my patient? So this addresses generalizability. Were all patient important outcomes considered? Are the likely treatment benefits worth the potential harm and cost? So again, you can see this flavor. Now we're, of course, we're talking about the final stages where the trial is done and we're thinking about how to implement this in our own clinical practice. But these elements are really important and those are addressed in pragmatic clinical trials. So some of the features of pragmatic trial, I wanted to highlight these two of pragmatic trials are the use of routinely collected health data like electronic health records or administrative health data, which is efficient in many ways, but also can be challenging logistically. And also it's quite cost effective. And then also we see randomization of treatment alternatives based on routine healthcare operations. So often this is done at the level of care. So for example, cluster randomization. And again, I recognizing that you have a lecture coming up about cluster randomization, we'll just go through some kind of key aspects. So I wanted to just briefly touch on administrative health data in this context, because I think it's actually an important part of pragmatic trial design, or it can be an important part of pragmatic trial design. So administrative health data are data that are collected for purposes other than research. And so we often talk about data collected by hospitals. Hospitals have to submit information to the Canadian Institutes of Health Information, and that information can be leveraged for other purposes. So it really uses pre-existing electronic mechanisms, which means increased efficiency and lower cost than having to go through a chart or contact a patient or other types of assessments. Now, this is less expensive and less administratively complex than clinical research studies that are more explanatory or traditional with their own, electronic data collection database that needs to be created. And sometimes that can be actually pretty costly. And there's lots of different types of data that can be collected, diagnoses, procedures, treatments, lab tests, and radiological investigations are just some of them. Again, in particular with administrative health data, there is a loss of granularity in terms of some of these things. So, diagnostic codes are often captured using, diagnoses are often captured using codes, right? The International Classification of Diseases, or ICD codes. And again, capturing some of these data relies on the people that the people who collected those data in the first place. And so there was a bit of a loss of, not control, but a loss of granularity around some of those things. And that can be a disadvantage, and was actually in our trial. And I'll go through that. So the way that administrative health data is generated, it's just important to recognize how this comes about. So, and people, this may be intuitive for folks, but it's helpful to remember that this data starts when a patient seeks healthcare, based on some symptom, and then they have an encounter with a health professional. Then they undergo like routine care that we would normally provide in the hospital or the clinic. The healthcare provider documents in the electronic medical record. Sometimes there's paper records. And this is then reviewed by people, coders, who then, summarize the key aspects of that and then send that information for filing to, for things like, as an example, the Canadian Institutes of Health Information. There's different databases. There's the discharge abstract database, and then there's the ambulatory care record as well. So it's just important to remember these data are opportunistic, and as opposed to a explanatory traditional trial where your data are very, there's a very strict schedule of assessments, including information from history, lab work, imaging, what have you, right? But there's a lot of benefit to using these data, as I mentioned, but also it's important to keep in mind some of the challenges. And so you need to know a little bit about why the database was created, how it was created, and then understand about, again, the completeness and the accuracy of the data. And so there is something that can be affected there in terms of accuracy and precision with respect to particularly things like diagnostic codes. And, people spend, it's worthwhile to think about, especially when you're designing these trials, if your data points are going to be involving diagnostic codes, for example, people to ensure that you're trying to use diagnostic codes that have been validated. And that's not always the case, that they're not always available, but it actually can be an important part of the story, particularly if it's like your primary outcome, right? And it's important to keep those in mind. So of course, like anything else, they have, the use of these data for trials can be hugely advantageous because they're already data that are already collected routinely. So now we're just using them for another purpose. They're available. They're available at a low cost. You can study a large number of patients and you can follow them longitudinally. So that's great. Again, the challenges are that they're opportunistic. So, if we're measuring all of the hemoglobins that a patient has when they're admitted to the intensive care unit, that may be different for different patients. Some patients might have, 20 hemoglobins and some patients might have 2. So that's important to remember. There can be issues about the completeness of data. There are challenges with accuracy and precision. And again, it's helpful when you're if you're thinking about using these kinds of data to make sure that you're using validated codes, or even do some validation work in advance of your trial, in preparation, if particularly, again, if that's an important data point for your trial. They have a limited number and type of variables. So you just have to be mindful of what is available. And then again, there's issues around data quality and integrity, and access can be an issue depending on, so for example, accessing provincial data in Ontario, many people will probably be familiar with ICES, and certainly that's a way to access provincial data, but often it may be easier even, for example, to access hospital data. So we'll just switch gears now and just talk briefly about examples of pragmatic trial designs. These are, just some of them. Again, these are trial designs that support trials. These are designs that support trials that are primarily pragmatic in intention, right? As opposed to having another type of trial design or more traditional type of trial design where there's pragmatic components or features. So these trial designs really support those types of questions. Registry-based trials, parallel cluster trials, cluster crossover trials, and stepped wedge trials. There's more, but these are like a few of the key ones. And so I did want to touch briefly on cluster trials, just because I think it's such an important design for pragmatic trials, but understanding that, Monica Talliard is like a world expert in cluster trial design. So she'll, I'm sure, will go into it in much more detail. But just to say that cluster trials randomize units of care as opposed to individual participants to an intervention or a control. And this is a really, important and powerful design, particularly if you're evaluating a policy type intervention, a complex, intervention, a pathway, this type of design. But you can also do, again, we're going to go through some examples of transfusion trials. So there are lots of pragmatic transfusion trials as well, where, some policies are applied to a unit of care, a cluster, a hospital, an ICU, a dialysis unit, a city, a clinic, as opposed to an individual patient. An important challenge with cluster, if people think about cluster trials, it's amazing what you can accomplish. But an important issue to remember is that patients within the cluster, you can see here, these are represented by different clusters with different colors. And you can see that there's color variation within the cluster because they're different people, but that patients within a cluster are more similar to one another than they are to people from different clusters. And so this relationship between people in a cluster is an important methodological issue in cluster trial design and affects statistical power. And we'll talk about that in a couple of slides. There are a number of reasons to choose a cluster trial design. And actually, if you talk to someone like Monica or others, methodological experts, the most important thing at the outset that they will ask you is, why does this need to be a cluster trial? And so it's really important to consider upfront, why specifically this trial is ideally designed as a cluster trial. And those can include things like to avoid contamination. So that would be, crossover between treatment groups, which would reduce the treatment effect. So in our trial, we conducted a trial where we transitioned ICUs to using blood tubes that collect less blood for lab testing. And we initially envisioned an individual participant trial, but then, it became pretty clear pretty quickly that there would be a lot of contamination because, people would just grab whatever tube was available and for whatever patient, and that we wouldn't be able to ensure that the intervention was applied only to the patients that it was supposed to be applied to. Cluster trials are often designed to represent real life practice or routine clinical practice. They can enhance efficiency and reduce costs by delivering an intervention to a group. They can also be helpful to improve the effectiveness of an intervention by applying it to a group. And you may, again, avoid some ethical concerns that arise when individuals in the same group are treated differently. So that's sort of an interesting aspect of this. But these are some examples of cluster trial designs. There's a parallel design, and again, Monica will go through this cluster cross. So parallel design is that you have each cluster is allocated or randomized to one intervention or control or intervention, one intervention or another. In a cluster crossover trial, the sites actually alternate between different interventions. And I'm only showing two crossovers here, but actually we're doing a trial where there are 12 crossover periods. So that's important. That's an interesting design. And then there's the step wedge trial where all the sites transition, but the timing of the transition is actually randomized. And I'll talk a little bit more about that. So again, when we're talking about cluster trials, there's this issue of intra-cluster correlation, or again, the correlation that exists between people within a cluster. And that's important because that means that the observations within a cluster actually have less variability than observations from the overall population. The reason this is important is because that means that your estimates of effect of your intervention or your treatment have a higher variance than an individual participant trial with the same sample size. So at the end of the day, there's a loss of efficiency, which means that more participants or more participants are needed to achieve the same statistical power. So that's why you'll see with cluster trials, many thousands of patients are often included in cluster. In our trial, there was 27,000 patients in the analysis, and people are like, wow, that's huge. But you need to do that because of this issue of the correlation between clusters. Between people within the clusters. I like this, and it's helpful maybe when you talk to Monica next month to just to reflect on this a little bit, so it will be familiar. But this is the intra-cluster correlation coefficient, or ICC. And so when you calculate your sample size for a cluster trial, it's assumed that two observations from the same cluster, so like, observations from two people in a cluster have a constant correlation between them, and that's what is known as the ICC. And so you can see this is like a just kind of a visual representation. If the ICC is 0, that means that there is no correlation of responses within a cluster. And you can see, here's different clusters, and there's eggs in the little baskets, and they're all kind of different colors, right? So there's no correlation. Whereas if the ICC is 1, that means all the responses within a cluster are identical. And so you can see here with these two clusters, all the eggs are white, and all the eggs are. So it just means that you have it reduces that, again, that statistical power, the statistical efficiency, and so you need a much larger sample size than you would if you were doing an individually randomized trial with the same clinical question. And so I'll just kind of that segue from that into, this is an example, it's a little opportunity for me to, it's a little shameless self-promotion, but I think it's helpful to review, an example, and I can go through a little bit about why we made the choices that we did. We conducted the Stratus trial, which was small volume blood collection tubes to reduce transfusions in intensive care. And that was published in JAMA a couple years ago, which was like a super wonderful accomplishment, and the efforts of like a lot of people. And our research question was, in adult ICU patients, does the routine use of tubes that collect less blood for lab testing reduce red blood cell transfusion? And so we were evaluating this intervention, which is blood collection tube. These are called short draw or soft draw tubes or low vacuum tubes. They actually have less vacuum in the tube, so they fill to a lower volume automatically. They have the same cost as the other regular size tubes. They have the same physical dimensions, so they go on the same equipment. They're not the little microtainer PD tubes. These are capillary fill tubes. So that's not what we were looking at, because those wouldn't have been feasible kind of on a large scale. But the important point here is that, and the reason that we wanted to pursue this as an intervention is that, when you take blood, 90% of the blood is discarded, like only, probably even way less than 10% is actually used for testing. There's a little bit of blood that you need to have in the tube just for the equipment, but these tubes are not routinely used in adults anywhere. It was sort of surprising to us that was the case. But here, became an opportunity for us to implement something that's already used in clinical practice. So we chose to do a stepped wedge cluster randomized trial. And this is a trial that's kind of an ideal design for the introduction of a new policy or treatment. And the intervention, in this case, it was the tubes, are introduced in timed steps. As you can see, that's why it looks like a stepped wedge. That's why it's called a stepped wedge. So that at every site receives the intervention over time, but the timing of that the timing of the transition to the intervention is actually randomized. But at the end of the trial, all of the sites have now implemented the intervention. So it's nice. It's a nice design, sort of for interventions that have a high likelihood of benefit and low likelihood of harm, because at the end, the intervention has been implemented. So we conducted this trial in adult medical surgical ICUs, and that were using small volume tubes. And actually, that's like the vast majority of ICUs that we surveyed in Canada. And they had to have electronic data available. So we started this trial, and you can see here's our cluster, our stepped wedge design. And things were going super well until March of 2020, when COVID hit, and we had to actually pause the study. So with that, you'll see this kind of pause and here. And that's a whole different discussion about extenuating circumstances. But just to say, we ended up finishing the trial, but we collected data, on every patient who is admitted to the ICU during this period, which was ended up being over 50,000 patients. And this trial was conducted under a waiver of individual participant consent, and we collected electronic data up to 30 days, or hospital discharge or death. I just wanted to, show, for the sake of time, just to kind of show briefly the results. We ended up considering 58 ICUs and included 25. 51,000 patients were registered. So they're not like enrolled in the trial, because again, this was a waiver of consent. So we did provide information sheets to patients and had posters in the ICUs. And so people could request to have their data removed. And actually, of one patient out of 51,000 requested data removal. Our primary analysis, actually, we ended up excluding that COVID period. And so that was 21,000 patients. And we showed that there was a non-significant reduction in red blood cell units per 100 patients. But when we included all of the patients in the secondary analysis, there was a significant reduction of red blood cell units per 100 patients, so 10 units per 100 patients. So it was a bit of a heartbreak, but there it is in research. Um, an important part of our study too was to be able to say that there wasn't going to be any issue in terms of specimen insufficiency, and so that was the main sort of safety concern or harm that the lab folks particularly were concerned about. And you can see that the number of specimens with insufficient quantity was low and similar between groups in both of the populations. And we analyzed hemoglobin. Remember that again, this is like opportunistic data collection, so it adds some complexity in terms of how you analyze these. But we looked at hemoglobin a number of different ways: adjusted for transfusion, the change in hemoglobin from ICU admission to discharge, adjusted for transfusion, just the overall change, and then the change in hemoglobin in patients who weren't transfused. As you can see, there was a reduction in the change. So that means there was a smaller change in hemoglobin, smaller change in hemoglobin when after transitioning to the smaller volume tubes, which kind of is in keeping with the whole principle of why we thought that this could be an intervention that worked. If you have less blood drawn, you have less hemoglobin loss and perhaps less transfusions. So in the end, it was a bit tricky, but we did show that transitioning to these tubes might reduce transfusion in patients in the ICU. I didn't mention, but we limited our primary analysis to patients who were in the ICU for 48 hours or longer. And we showed that a decrease of 10 red blood cell units per 100 patients in our secondary analysis only. We can have a separate discussion about what that means. We also showed that transitioning lessened the ICU-related reduction in hemoglobin, but we did not see an impact on lab testing. So, one of the challenges, of course, like, why did we choose this design? I think it seems, that at the time, again, we did waffle back and forth about should we do ICUs, should we do hospitals, should we do individual participation, should we do cluster? I think we landed on the right design. This was an intervention that was implemented as a policy within the ICU, and we wanted to implement this by the end of the trial, because even if the trial was totally negative, if there was no harm associated, there is no extra value added by taking more blood than you need to, right? Like that's just wrong. And if you tell patients in the public this, they just actually, it really, they find it rather surprising. That this is the case. But, with regards to the pragmatic components, we implemented this right into routine practice. So like the people, we changed the purchase order, the barcode in the storage area, the tubes were ordered, on the day of transition, and then the nurses used the tubes, the lab processed the samples. Like this was all done in routine care. Our data collection was purely electronic, so pragmatic and cost effective, but also a beast. Like we ended up with a data set of 450 million data points, and I think we totally underappreciated the complexity of combining those data sets and cleaning the data and analyzing them. So just kind of a cautionary note. And I think, at the end of the day, we did show like that there was a small effect at the individual level, but potential for impact, at the health system level. So, for us, and I just wanted to summarize it here, over 35,000 transfusions were administered to these 27,000 patients. Like 36,000 transfusions in less than 2 years in just 25 ICUs in Canada. So there's 250 ICUs in Canada. So if we were able to reduce transfusion by 10 units per 100 patients, that means that we saved, 400 units in this trial, which I think, sounds a lot more impressive than 10 units per 100 patients. But I think at the end of the day, there's so many pragmatic components to this trial, which would not have been possible with another type of design, I think. And the total cost of the trial was $750,000. So just kind of give you a sense of the cost efficiency that was created. I'm just going to skip this. I wanted to, just highlight another trial that we're doing just for discussion or just to contrast. So this is a trial I'm working on with Jessica Spence, who's at McMaster, looking at a technique to prime cardiopulmonary bypass to reduce transfusion in cardiac surgery. And so this is, again, a highly pragmatic research question, which was, does an institutional policy of using routine autologous priming, so that means like taking the patient's own blood and circulating it through the tubes in the machine, does that reduce red blood cell transfusion within 72 hours compared to using, a crystalloid fluid? So again, this is a pragmatic trial about clinical effectiveness, not efficacy, so highly pragmatic. And as you may or may not know, transfusion super common in cardiac surgery, where almost half of patients receive a red blood cell transfusion. And it appears from observational data that if you use the patient's own blood to prime the circuit, which is here, this is like the representative example of a bypass machine, then you can reduce hemodilution and red blood cell transfusions. And so there may be some benefit. So these interventions, again, are applied as policies. So you have the RAP, or routine, the retrograde autologous priming policy, and you have the crystalloid policy. And so those are applied routinely, and there's some room for exceptions. But what we wanted to see was that the use of these policies was over 90% in the trial. And so we designed this as a cluster crossover trial. Remember, that's when the sites cross back and forth between those two interventions, where the hospital is the cluster. And this is a pilot trial. We've just completed the pilot phase. And actually, we had a great result, which was over 90% adherence to the policy, which is fantastic. So hopefully we'll be seeing this as a full trial design soon. And this is just an example of like that randomization schedule where you can see there's 4 sites here. These are the 4 pilot sites, and there's a random sequence of transitioning from one intervention to another over time. So it's not just like A, B, A, B. You could see that there's like A, B, B, A, B, that sort of thing over time. And so it's very helpful to, there's some other methodological design considerations that make this kind of a design ideal. And we're doing right now, again, we've just completed our Vanguard phase and hoping that will be funded for a full trial sometime soon, with fingers crossed. But I just did a brief scan. And so this is by no means like highly inclusive, but there's lots of designs. There's lots of examples of pragmatic transfusion trials in pragmatic transfusion trials. On the left there, you can see the trial that was done by Dean Ferguson and Michael Chassé and maybe others on the call regarding the effect of donor sex on recipient mortality in transfusion. There's this one here is the proper randomized trial. So this is the 1:1:1 versus 1:1:2 ratio in severe trauma. This is a cool trial, SWIFT, that I saw, which is a study of a whole blood in frontline trauma. So this is a study that I think maybe people know more about this than me, but I thought it was super cool. I couldn't find like a good diagram, but it's pre-hospital transfusion in the UK. So that's kind of a cool trial. There's Alexi Turgeon's trial, which is a transfusion strategy in aneurysmal subarachnoid hemorrhage. And again, some of these are more or less pragmatic. Some of them are individual participant trials with pragmatic elements. Some of them are like this one is a trigger. This is a threshold. Transfusion threshold and GI bleeding, which is a cluster trial. So again, I think there's lots of room in transfusion medicine to conduct, highly methodologically rigorous pragmatic trials and not only answer important questions, but also, can inform, patients, researchers, policymakers. And so I mean, I'm glad to have this opportunity to discuss it because I think, as we get more experience with these trials, as a sort of a community, we can just see more and more of these and facilitate the translation of good evidence into clinical practice. And so I'll just end with these, kind of key messages, and then we have a few minutes, that again, going back to the beginning, pragmatic and explanatory intentions impact your trial design. And so really at the outset, you're setting in place your intention and design your trial based on that intention. Transfusion trials can incorporate both explanatory and pragmatic elements, and sometimes, and no trial is exclusively one or the other. Whether or not it's a spectrum or these are related, distinct, but interacting elements is, I think, sort of up for debate. But a lot of these pragmatic trials do require expertise. And so it is helpful, if this is something that people are interested in doing, to make sure that you connect with the right people, who have expertise in this space, and particularly methodological expertise, people like Monica Talliard and others, Shunfu Lee, who is our biostatistician at PHRI, just to, give you a sense of how to get these done. well. So I'll end there, and hopefully that leaves us some time for questions.
Thank you so much, Deb. That was really well explained and super helpful. Maybe I'll just ask if anyone in the audience has a question. I think we've got a few people from other organizations besides the CTTG joining us today, which is fantastic. But any questions for Deb?
Hey, that's
Hi,
so
Jeannie.
great. Do you think there's any um, role now for a non-Bayesian randomized controlled trial? Like, we're putting so many patients into clinical trials, and you come out at the end of the day, like the MINT trial with, that's, I don't know, like, like, is
Yeah.
that okay anymore? Like, is it really okay to randomize so many patients and not be certain that that they're consenting into the trial is going to benefit humanity, and that we need to be doing trials in a different way, and that's just a thing of the past, and that we need to move onwards to something where we always get a really good answer from the trial?
No, I think that's again, I love it. It's important to always think about like how can we do better. We do have these discussions all the time, so I agree with you. I'm not that familiar with Bayes. We may have talked to Ryan Zarachansky because this is his like kind of platform right now is to think about Bayesian designs. And do away with kind of that traditional RCT, where I think what part of the problem is we're also locked into this framework of like the p-value of 0.05, and a trial is all you're 0.04 and you're like it's amazing, this changing practice, and you're 0.06 and you're like, oh, it's a flop. So I do think that there's part of it. I don't know that we need to do away completely with those trials, but two things. One is this kind of p-value issue where we what's it called? We adhere so strictly to those criteria, and I think that there's a lot of important information that just gets dismissed because it's point p is equal to 0.06, and that those trial results still could have important, results for patients. And then the other thing is, I think we ought to do a better job, and this is where pragmatic trials have such a good a benefit, is to really think about implementation right from the beginning. And so some of the challenges are, so even if we have those amazing clinical trials where the p value is significant and there's a benefit, there's the challenges of generalizability, but there's also this implementation piece that we just don't think about at the beginning. And so we have tons of trials which just never get implemented. And so that's also an ethical problem to me, right? So thinking about from the beginning, how can we design trials? How can we evaluate implementation, challenges, and think about mitigation strategies like from the beginning to be able to get those results into practice when they're available. I do think probably there's a place for both, but I hear what you're saying. In terms of interventions, we already got lots of interventions that work. We just don't use them. And if we're using them in routine practice, we should be able to compare them in routine practice. These are arbitrary things that are often done. But some questions like, novel drugs and treatments and things like that are probably best studied, at least initially, with a traditional randomized trial. But then there ought to be this sort of follow-up, like implementation piece, which we just don't really do, right? So you're like, okay, I'm done my big New England Journal of Medicine, cardiovascular trial, and that's it, and that those results never reach patients. So I hear what you're saying. I think we ought to come up with better ways to implement these changes, because if we're not going to change practice, then where are we going to do this, right? Yeah.
I might ask a follow-up question to that. I think, when your intervention is taking blood out of a patient, such as the Stratus trial, or, when your intervention is, trying to get laboratory technologists to screen orders, like with Jeannie's START trial, I think in those situations, you can be pretty confident you know what your intervention is doing. And I'm almost kind of wondering if we actually have not actually got to that point when we're putting blood into a patient. We don't actually know what the physiologic effect is. We think we do. And to my mind, I think this is partly why when we have all these pragmatic trial designs, we get these very murky results. I think the MINT trial is a good example. These last series of trials involving acute brain injury or another. the trials are broadly negative, but there's a signal that somebody in there is benefiting from this. We're not teasing them out with our predefined subgroups, and so we're kind of left going like, okay, something is going on here with the transfusion. Even the trick trial itself, like it was hurting people, the transfusions. We didn't know why, and my feeling is that we're actually maybe swung a little too far to the pragmatic side. We need a little bit more of an explanatory angle. And I appreciate your saying that it's not either or, that there's, but I think about that trial of, bleeding for acute GI bleeds that came out of Spain, where they actually put in these splanchnic pressure monitors. And I'm sure that was incredibly expensive and tedious, but at the same time, thank God they did that because otherwise we would have had no idea why the transfusions, I mean, we'll be conjecturing why. So I feel like maybe, it's one thing if you're talking about chemotherapy or cholesterol drugs or blood pressure medications, but when you're putting blood into somebody, maybe we don't really know well enough what it's doing to do so many pragmatic trials or do some purely pragmatic trials. I don't know. What do you think about that?
No, I agree with that, and that's why I think that transfusion medicine is kind of a nice space for these for some degree of and that for pragmaticism. But I also think that there's an opportunity to, as you kind of say, have there's a pragmatic design with an explanatory piece, or an explanatory piece with a pragmatic component. Like I think both can coexist, and people are talking about that more. That it's not so much a continuum, that it's actually like this interaction that exists, which I think probably resonates with me more. um, that's where I think, and maybe Jeannie was alluding to this too, this sort of idea of these Bayesian trials, where, as you go, like you use your kind of you still use, your pre-existing observational data to inform your study design and the effect that you're going to see, but you can accumulate evidence as you go. And then there's an opportunity to study subgroups in a different way to be able to try to identify. If you talk to Ryan Zarechansky, he might have already presented for you guys on this, but but there's an opportunity to kind of tailor it to the subgroups of people within the trial who are most going to be benefiting from it. And so there, it does hold that promise. Like I don't know that we've seen, like it's kind of like show me the money. I'm not sure that we've seen that play out, but I'm hoping that we'd be able to say, with advanced methods, it's just a challenge to be able to implement these and do them, right? They're hard to do and conceive of. And you're right, like in a lot of these spaces, a lot of those transfusion threshold trials have been disappointingly negative, right? Like, except for Trick. Yeah.
Which was sort of confoundingly positive,
Yeah.
We
So I
still don't
think,
know what happened, but
yeah, yeah. So I think, are there are there other outcomes that can be evaluated? So I think that's part of it too. It's not just like the design itself, but some of the design features can certainly be pragmatic, and then still have like an explanatory piece. But I agree with you. It's an important challenge.
okay, we've got maybe time for one more question, and it's in the chat. This
Oh
is
yeah.
about would platform trials be considered pragmatic trial design or explanatory?
Oh, I haven't thought about that so much. I guess it depends on the type of platform. So, again, I think with these new trial designs, they probably have components of both. So if you have like an ICU, if you're doing, for example, in COVID, there was a trial which looked at, patients admitted to ICU during COVID and using heparin for prophylaxis of venous thromboembolism. And so every patient that it was admitted to ICU was included in that trial, pretty much, or everybody was eligible for that trial pretty much. There was very limited exclusion criteria. So that would have been kind of some explanatory, some pragmatic component. But then some of those questions are actually, can be very explanatory, or they can be comparing like two things that we already use in clinical practice. So you're comparing like azithromycin and ceftriaxone, and that's a comparative effectiveness question. And that's much more pragmatic in nature. So I think it depends a bit on the platform and what's being evaluated. For new cancer drugs, there's lots of platform trials about new cancer drugs, and those are probably highly explanatory. So again, I think it's variable.
Okay. All right. Probably, I think we'll have to wrap it up now. And I think we always know we've had a successful presentation when we run out of time for questions because there's so much stuff to talk about. But thank you so much, Deb.
Okay, thank
Really,
you. That
really
was really
helpful.
great.
Yeah, really happy to have you here.
Okay.
I will just quickly just put up um, the next month's. Oh, hold on. What have I done? Here we go. We will be coming back in December, and as Deb mentioned, Monica Taliad will be talking specifically about cluster and step wedge trial design. And then we do get Ryan Zarachansky next
Oh,
year.
good. That'll be really good.
For adaptive trial design. Thank you so much, everyone, and we'll see you next month.
Thank you. Have a good day.